Thank you so much to the IRSI Youth Wing for inviting me here. And I'd be speaking on the judicious use of lubricant eye drops. No financial interest in any of the products. I'd like to start with a statement. Good judgment comes from experience, and a lot of that comes from bad judgment. So, friends, I would like to urge you all to learn from your experience and learn to take judicious decisions, especially when it comes to choosing the best lubricant. Very often we face this, where a patient who has been prescribed a lubricant eye drop for dry eye has come to us for a second opinion. Not satisfied, goes for a third opinion. Still unhappy, goes for a fourth opinion. Hasn't it happened to all of us? And then each doctor prescribes another brand according to what he thinks is right, according to what he feels works. And finally, the patient may remain unhappy, may remain unsatisfied at the end of his journey of the doctor hunt. If you look at the economic burden of dry eye, it not only accounts for almost 25, and I feel now that's even higher in our case at this point of time of medical eye care visits. But if you see the estimated cost to the US healthcare system, it's a whopping 3.84 billion annually, and that's increased to 55.4 billion if you consider the societal costs. And look where we are today. Today, we have simply too many choices. We are spoiled for choice. And it's absolutely natural for my opponent to feel confused as to what should I choose because there are so many lubricants available today. I might just switch from one brand to the other. But remember, friends, not all lubricants are equal. There are key differences between ocular lubricants depending on their composition, their viscosity, whether they are aqueous based or lipid based, what is the preservative in them, what's the mechanism of action, efficacy, and the osmolarity and the presence of osmoprotectants. And hence, friends, remember, one size doesn't fit all. If you look at the pathophysiology of dry eye, it's no longer just a tear film instability. It's also inflammation, it's also hyperosmolarity, there is apoptosis, and there are different therapies that act at different points in this circle. So you cannot have one drop being used at every point or any drop being used at every point. Also, according to the severity of the dry eye, you will need to change the kind of lubricants that you're using. You'll also probably need to change what other accessory drops that you're going to use and other ancillary treatments. Again, remember that our tear film has a lipid layer, the aqueous layer, and the mucin layer, and there are specific topical eye drops available which are targeting the therapy at each level. So you have to look at what is the patient's specific problem and look at their problem and then treat accordingly. So let's see what's the clinical effect finally of an artificial teardrop. Is it just that they lubricate? Do they just replace the missing tear constituents? Do they reduce the elevated tear film osmolarity? Or do they wash out inflammatory agents or they act actually as anti-inflammatory? So an ideal tear substitute should not only or not alter the lipid layer, not alter clarity, it basically lowers the surface tension, it enhances the tear volume and forms a hydrophilic layer. So you should have an ideal pH of 6.5 to 7.5, a viscosity of 6 to 12 CPS, and an osmolarity of 302. Now, if you dissect the anatomy of an artificial teardrop, the main ingredient is the demulcent or the hydrogel. So you will have preservatives which will help to prevent any contamination. You'll have ions which will maintain the stromal hydration and restore the barrier function. You'll have buffers to maintain the pH, and you may have some oils to protect against evaporation. The basic demulcent acts by soothing the mucous membranes in the form of a mucoprotective film, and it alleviates the discomfort, it decreases the friction across the ocular surface. So basically, they can be categorized as either the cellulose derivatives, which, as we all know, are the CMC, the HEC, HPC, and HPMC, and the polyvinyl polymers, which have the polyvinyl alcohol, polyvinyl pyrrolidone, and the polyethylene glycol. So what basically differentiates the two of them? We need to know that. So the cellulose derivatives are basically polysaccharides. They are more beneficial in aqueous deficiency. If you use hyperomellose, they can cause crusting of the lids. And that is why if the viscosity is higher, that could lead to blurring of vision. So a patient could come back and tell you that he is not able to see clearly after using them. The polyvinyl alcohol based are basically synthetic polymers. They are beneficial in lipid, aqueous, as well as mucin layer deficiencies. They have a shorter retention time. They are water soluble and hence usually do not cause blurred vision. Now, as the viscosity of the cellulose derivatives increase, the retention time increases. However, they could cause blurring of vision. So you need to know what exactly comprises in the brand that you're using, what exactly you are giving to the patient according to the needs of the patient. For example, if you take the simple CMC, we need to know that it has a mucomimetic property. That means it simulates the action of mucin on the ocular surface. It not only retains the water, it acts as a surfactant to lower the ocular surface tension. It acts as a mucoadhesive, and that is why it protects the ocular surface epithelium and promotes the corneal epithelial healing. You need to know the science behind it. You cannot just use it randomly just because you think it works. Remember, the CMC forms a complex with a fibronectin which attracts the epithelial cells, accelerates the epithelial cell migration as shown in this picture. Comparing all these drops, you know that CMC today has the highest mucoadhesive properties, more ocular residence time, more regeneration of goblet cells. Now coming to hyaluronic acid, it's a glycosaminoglycan. It also has a specific receptor, the CD44 on the epithelium to promote cell migration. So it has a good ability to retain water and hydrate the ocular surface. If you compare the comfort index value, you need to know this, that if you compare them, the hyaluronic acid is higher on the list, followed by HPMC, then CMC, and then the rest of the drops. Now, if you have a patient with MGD, what is basically problematic is the lipid layer deficiency, and that is why these fat or oil or lipid-based ointments would probably help better. They have higher retention, but they can also cause blurred vision. They will help to stabilize the tear film, reduce the evaporation, but typically they should be used at night, and a solution should be used prior to them. Now, what is the use of osmoprotectants? You don't need just a CMC or you need a hyaluronic acid. You also need osmoprotectants like L-carnitine, erythritol, taurine, trehalose. So you need to see whether your drop has all these things. What happens is this helps to stabilize the cell membrane lipids and proteins and protects the corneal epithelial cells from death by desiccation. Now, coming to preservatives, you need to know whether you have BAK in your drops because that's going to be more toxic. Remember, your patients are going to use this 3, 4, 5 times a day. You have vanishing preservatives today, but what I usually prefer, and definitely for moderate to severe dry eyes, preservative free, especially unims, are preferred, even though they are more expensive. Especially in those patients where the frequency required is more. Patients of glaucoma, for example, if you have chronic multiple anti-glaucoma medications, post-operative patients, acute keratoconjunctivitis, preservative-free formulations are what you would prefer scientifically rather than being just a random drop. Also remember to look at the compliance. Now, patients may not afford these expensive preservative-free drops, may not want or may not be able to put multiple daily dosing. They may have burning and stinging. A patient whom you have prescribed comes back to you saying that he cannot tolerate. And you're saying, no, this is a drop meant to help alleviate your discomfort. Remember, the patient's tears pH may not align with that of that instilled drop. You need to educate the patient not only for the drop, but also how he can use humidifiers, drink more water, see that the AC draft doesn't come directly on your eye. Also teach him how to use the unit dose wire, which may be challenging to the patient. And most of all, understand the primary deficiency of your patient's tear film. Know your lubricant eye drop. It's not just important to know the name of your brands and see which MR meets you, but you need to know what is present in that brand. So you may have a patient who is already using one brand and you come and you start another prescription, but which has the same actual molecule. So this is not going to help the patient. Challenges continue, friends, and medical management may be limited. You need to have to treat the cause for better visual outcomes and outcomes for the patient. So you need to add anti-inflammatories like steroids, cyclosporin A, and treat lid margin disease. So we all know cyclosporin inhibits T cell activation. We all know trehalose helps to protect corneal epithelial cells from apoptosis after desiccation. We know chloroquine helps to reduce inflammatory cytokines. And yes, you have newer technologies, you have IPL, you have LipiFlow, and all this is going to augment your treatment if patients are not responding to your usual treatment. So coming to my treatment pearls, what I do in my practice, if a patient has a mild dry eye, we usually start him on 0.5% CMC or HPMC or a carboma. Or if it is little more increased or if it's moderate, then we add a polyol or you can use a polyol separately. If it's severe, then we go on to 1.1% CMC because of high viscosity or hyaluronic acid with osmoprotectants. You may also combine two different tear substitutes with different mechanism of action. But ideally for a severe dry eye, we usually prefer a totally preservative-free unims. And yes, ointments and gels for lipid deficiencies. So we do not want to do just a hit and miss kind of treatment. Friends, today it pays to be judicious and you will pay if you don't. Thank you so much for your kind attention. Thank you.